Can you all hear me?
Yeah.
Okay. Hello, I'm Helen. Thank you for coming. I see some familiar faces. So this is the second version or the repeat of what I did yesterday evening. And it's the same information. And thank you so much for coming. This has been on my mind to do ever since I moved here to Oregon. And I'm so grateful to the library and C3 for helping to host these education sessions, and to the Grace Center for providing respite care for caregivers who can't attend, otherwise because they're caring for their loved ones full time. So today's talk is the first of a 4-part series, which will go through this entire year. It'll be offered twice. Our vision is to offer each session twice, Thursday evening and a Friday noontime, so that we can provide accessibility to as many caregivers as possible. So spread the word. Today, I will be focusing on what I call Dementia 101, which is sort of the bread and butter information that I think is really helpful to understand if you are either newly diagnosed with dementia yourself or you are caring for a loved one with dementia. The next session, which will be in June, will focus on sort of how do we adapt care over time as dementia changes. As we all know, there is no cure for any of the dementias, and so they will all progress over time. And then the third one in the fall will be about how stress affects dementia, all kinds of stressors. And then the last one before the turn of the year will be focused on very practical tools and ways to manage what are sometimes called dementia behaviors. And we'll have some actual tools and things here for you to touch and feel and sort of see when we talk about these things, what they are. This is a picture that a photojournalist took of me in 2012. I've been doing this work for almost 20 years, home-based work, and also dementia care since I finished my geriatrics fellowship. A lot of people are probably wondering, why is a hospice organization providing dementia education? Well, my primary specialty is geriatrics. I did a fellowship in geriatrics, and then I got double boarded in hospice and palliative care, but I always consider myself a geriatrician first. So dementia care is very integral to everything I do and think about. So I'm just throwing up a few examples. There's 1,000 examples I could have put here, but some of this will be familiar to you. I told him 5 times not to do that. Or he keeps urinating everywhere except the toilet. My wife won't sit still to eat. Dad insists someone is coming after his money. She keeps falling, missing the chair. Mom was always very sweet, and now she is nonstop cussing. And I try to tell him those people he sees aren't there. So I'm going to come back to all of these at the end of the talk. And my hope is that by the end of this, I'm going to walk you through how I, as a healthcare provider and a geriatrician, sort of think about these things, because our goal as a caregiver, my goal for you, my wish that all healthcare providers would do, is to be a lot of that detective work and sleuthing that it takes to be a creative and successful caregiver. So this is kind of the roadmap for today. We're going to talk a little bit about normal aging brain changes. And then we'll talk about the sort of general brain functions, and then talk about the different subtypes of dementia. And also the diagnosis of dementia, what ideally in the real world your loved one would go through to get a diagnosis of dementia. And then at the end, I'll talk about the bulk of this talk, which is the cognitive domains, to hopefully help you understand how deficits turn into the symptoms that you see. Actually, I'll just say, so these are my grandparents on my dad's side. 3 of my grandparents had dementia and had very different manifestations. Both of my grandmothers had what I would say is the pleasant, wonderfully forgetful but sweet dementia. My grandfather in this picture was extremely paranoid, very aggressive, extremely violent, broke my mother's arm at one incident. So this is all very personal to me, and this is why I do this work. All right, so this is a side view of the brain. And I think most people know and think about, because we hear about strokes. So the right side of the brain generally controls left side motor function. The left side of the brain generally controls right side motor function. People also tend to hear about, the sort of creative side of the brain versus the intellectual side of the brain. And so the right side tends to deal with abstract reasoning, the left side with language. And I'm basically going to go around the brain to sort of tell you what different parts of the brain do. There is overlap, but there's general functions to each section. So the cerebellum, which is here at the back of your head where the neck connects to your head, is our balance and coordination center. So someone who has cerebellar injury or cerebellar atrophy tends to have very wobbly walking and gait. They can't maintain their balance. Someone who has chronic alcohol use disorder tends to develop impairment in the cerebellum because of alcohol toxicity. And so they tend to be very wobbly on their feet. The occipital lobe is back here in the back of the head. This is our vision center. It's where we process a lot of vision. So this is where we link an eye image to a memory image. So that way, if I look at Kelly, I know that I've seen Kelly before and she's familiar to me. And that's how we process vision. The parietal lobe is kind of up here on the sides, upper sides of the head. This is our sensory area where we integrate a lot of sensory information. So temperature, taste, touch, movement. It's also where we have perception and can manipulate objects. So the example that I gave yesterday, which I'll do again, is if I give my colleague Molly, who's sitting in the back, I have her close her eyes and I give her a big paper clip and I say, touch this and tell me what you think it is. She could touch the paper clip and say, that is a paper clip. And that's our parietal lobe working. Our frontal lobe, which is right here in front of our forehead, behind our forehead, is where we have conscious thought, behavior. It's a huge part of our personality. So individuals, which you may have heard of, who have frontal temporal dementia or frontal lobe dementia tend to have drastic changes to their inherent personality. This is where we do a lot of organizing, a lot of problem solving. And it's also where we have the center for Broca's expression. So someone who has Broca's injury to the Broca's area will have difficulty with expressive language. They often have what we call expressive aphasia. So that's the frontal lobe. The temporal lobe is on the sides here, kind of behind the ears. And this is where we have some other sensory inputs, smell and sound. It's also a place that we process complex stimuli, faces, sceneries, and very importantly, from a memory standpoint, it's where we form and retrieve memory, along with the hippocampus. Now, Alzheimer's type, which is the most common type of dementia, tends to cause damage and shrinkage in the temporal lobe area. The other thing that's important to know about the temporal lobe area is that it is the area of what we call Wernicke's comprehensive language ability. So in contrast to Broca's in the frontal lobe, where it's about expressive language, putting out language, Wernicke's is about receiving and understanding language, to read something, to hear someone say something to you and to understand that. The insula is kind of deep inside the brain. And this is our area of what you may have heard of called emotional IQ. So cognitive emotional processing, empathy, our emotional intelligence center. And then the hippocampus, which is also kind of deep inside the brain, is where we process memory. And the hippocampus tends to be damaged or impaired in Alzheimer's type dementia, again, using that example. It's where we have verbal memory, spatial memory, in addition to the temporal lobe, is a big center of memory formation and retrieval. And then also deep inside the memory is the place called the amygdala. I think a lot of people are familiar with the amygdala because when we talk about things like stress and fight and flight, that's all processed through the amygdala. So this is where we process emotions, stress response. It's where we regulate stress response. And so when we're trying to teach kids to regulate their emotions, we're trying to help them develop their amygdala function. And it's also where we connect memories to emotion. And I bring that up because as we study and learn about dementia over the years, we know that things that have a very profound emotional impact to someone tends to be retained in the memory a lot better than other things. So for instance, I can tell you very well lots of things that happened to me emotionally. I can't tell you a thing about what I learned in college physics because that was not emotionally that important to me. So. All right, so the brain is just amazing. And if I wasn't a geriatrician, I'd probably want to study neurology, although I don't really want to be a neurologist. The brain does a whole lot of things, including integrating information. But I think what's remarkable about the brain is that it does a whole lot of things that you don't even think about. So the brain is the site of activity that controls our breathing, our heartbeat pulse, our digestion, when we have to pee, when we need to have a bowel movement. And if there's any dysregulation with brain function, then some of those, what we call autonomic functions, begin to have trouble. And we see that with some dementia. It's also a place where we have tremendous capacity for integrating information. Everything that we receive through our senses has to be processed through our brain to make meaning out of it and for our bodies to know what to do with that information. Now, as opposed to what we think of with the heart as the site of emotion and feeling, it's actually the brain that is the site of emotion and feeling. So I put up these examples because I just love the fact that we have emojis everywhere, and everyone's familiar with emojis. But what I find just from a neurologic standpoint very fascinating is that we can look at these tiny yellow circles with 2 dots and a line, and maybe that line is a little bit curved up, or maybe it's curved down, or maybe it's straight. And I could point to any of you, and you could immediately say, I know what emotion that emoji is trying to convey, right? Now, all of this actually comes from very careful neuroscience work looking at things like repetitive pictures of someone making all kinds of facial expressions. So this gentleman, is captured in 8 series photos making different facial expressions of a feeling he's having. And if you look at the top 2 right pictures, you'd be like, well, they're kind of similar. His mouth is really big and they're curved up. He's got a crease on his cheeks. But the second one in, his eyes are really big, and the one at the end, his eyes are really squinty. So I'd say, well, the second one from the end, this guy is super surprised, and the one at the end, he's sort of shocked and embarrassed. So these subtle changes to our facial expression that convey different feelings. And what's interesting about sort of knowing how our bodies work is that when we have some kind of emotional stimulus, so for instance, if I suddenly see a gigantic big bear chasing after me, I am going to have what we call an autonomic response. I am going to start sweating, and my hair is going to stick up on my end. My heart's going to start going really fast. I'm going to breathe and hyperventilate. And then that information tells my cognitive brain, be scared, I'm afraid. I don't immediately feel scared and afraid by looking at the bear. It's when my body has this emotional reaction, again, this autonomic part that we don't even have an awareness of, that I then have the cognitive feeling of, I'm scared. So I bring up all of these things in terms of feelings and emotions because one of the things that's really important to know as you're caring for someone with dementia is that even when language deteriorates, is that often the individual with dementia still can interpret facial expressions, tone of voice, and emotion and feeling. In some dementias, that begins to go away too, but in many dementias, there's still a retention of understanding feelings. All right, so there's a huge spectrum of cognitive function going from normal aging changes to mild cognitive impairment to an actual diagnosis of dementia, early, middle, advanced stages. What I will say is that in general, in our country, sadly, in most healthcare settings in primary care, most people do not get diagnosed with dementia until they are often in later stages, moderate or advanced stages. This is because we do an awful job of screening and identifying dementia earlier in someone's course. So often some of the things that can be done from a planning standpoint and really getting your loved one's actual input on what they want for their care in the future, sometimes we miss out on that because we don't diagnose until later. So what is normal age-related cognitive changes? This is, again, my grandparents, 1994, it was I think their 50th anniversary, 50th anniversary. So normal age-related cognitive changes is where you do have some increased difficulty with complex and difficult tasks. You will have some slower information processing, but you can still learn things. I know lots of people in their 70s and 80s who have learned how to use Alexa and smartphones and all kinds of apps. So there's still plenty of learning to be done. You will have greater difficulty with recall than recognition. Recall being the ability to, on your own, just pull something from your memory back out to use it. Whereas recognition is, you can't quite do that unless you have a clue or cue or note reminding you of that thing. And then it is actually common to have some word finding, some name finding difficulty. So just because you have a little bit of, forgetting, I can't remember what Uncle blah, blah, blah's name is, like that doesn't mean you have dementia. That can be part of normal aging changes. So this is my grandparents about 5 years later. At this point, their cognitive function was declining further. And I should say that my grandfather had a 5th grade education and my grandmother had a 1st grade, kind of kindergarten, 1st grade education. So they were very low literacy to begin with. But what you see in mild cognitive impairment is a cognitive decline that is more than what you would expect for age and education level. And the important part is that it does not yet interfere with function. So they are still independent, they can still do all of their own things, but you're noticing that perhaps they're more forgetful, more word finding difficulty, etc. All right, now we get to a diagnosis of dementia. Now in medical journals and in the medical science now, it's actually being relabeled major neurocognitive disorder. Most people still use dementia, but the reason why that was done is to recognize that a lot of people assume dementia is only older adults, and there are many individuals in their 30s, 40s, 50s who can develop young onset neurodegenerative disorders. So major neurocognitive disorder is trying to capture that, as well as to help recognize that most people think of dementia as just Alzheimer's. And as we know, and what we'll talk about, is Alzheimer's is one of many types of dementias. So to have a diagnosis of dementia, you have to have an impairment in at least one cognitive domain, the domains which I will go through in this talk. Now, memory impairment is not required at all in a diagnosis of dementia. And a lot of people, this is where, again, everyone thinks of Alzheimer's, memory deficit. You don't have to have a memory deficit to be diagnosed with dementia. Because again, there's 6 cognitive domains, so there's a lot of domains that can be impaired. Now, many people do end up developing a memory impairment, even if they didn't start off with one, but it is not a primary diagnostic criteria. The deficits have to represent a change from prior level of function. They have to progress, again, because we know that there is currently no cure and these conditions progress. And it cannot be associated with what we call an episode of delirium. Delirium is an acute, usually related to medication misadventure or an acute illness, where someone has cognitive disruption. This often happens to a vulnerable person in the hospital, who is suddenly like yelling and screaming and trying to climb out of bed and can't recognize their family. And so that is not dementia. It might overlay dementia, but that in and of itself is delirium. Now, as I mentioned earlier, that mild cognitive impairment does not impair function. To have a diagnosis of dementia, you must have some impairment in function. So that is required. So this is theoretically how a primary care provider or a neurologist would be making a diagnosis of dementia. Now, this is kind of what the steps are usually, but I will say realistically again, because many people are being diagnosed when they're already at moderate or advanced stages, sometimes it's already very obvious that the person has dementia. But ideally, as a healthcare provider, I would get patient information, find out from the patient what's going on. But because we're talking about dementia, I can't necessarily rely on that information alone. I have to get corroborative information wherever I can get that from a spouse, a child, a friendly neighbor, the Meals on Wheels person who delivers every week and is noticing that something is a little bit off with the person that there is the client. So corroborative information from wherever I can get it. Some type of formal cognitive evaluation, and I'll show examples of those later. For primary care purposes, there are a number of validated short 5, 10, 15-minute validated tools that can be used for PCPs who only have 15 to 20 minutes to see a patient in primary care. And then most helpful in complex and atypical cases would be the full neuropsychologic testing. This is where you're seeing a PhD or a doctorate of psychology. This is the 3 to 4 hour long battery of tests. It can be very difficult for someone to go through, but it can be particularly helpful when we're talking about young onset dementia, someone who has long-standing psychiatric illness, someone who has a very, very high intellectual baseline, so that on the more simple 5-minute tests, you're not quite capturing full impairments, or someone who has a very low intellectual baseline or perhaps has some learning intellectual disability to begin with. So that's where neuropsychologic testing is helpful. Imaging may be helpful. Imaging does not make or break a diagnosis, and it is not the sole criteria for diagnosing. If I look at a brain scan and the brain is real shrunken, I can't assume that that person has dementia, but it can be helpful. A functional assessment, because of course dementia has to impair function. So I need to know what are the things that the cognitive impairment is causing in terms of a functional decline. And then as a healthcare provider, I need to be sure I'm ruling out other reasons for cognitive issues. Is it severe hearing loss that hasn't been addressed? Is it, someone who's a closet, alcoholic and has never been identified, and that's why they're impaired? There's lots of other reasons medically why someone may have some impaired cognition. Now, I get a lot of questions about specialty tests, specialty blood tests, cerebral spinal fluid tests, special scans like a functional PET scan or a DAT, which is a dopamine scan. These can be very useful. Oftentimes insurance doesn't cover these. These are still mostly used within the realm of clinical trials and studies, where the researchers need to be absolutely sure that the person that they have identified for their study is Alzheimer's type and not vascular type, or vice versa. And so this is kind of where those tests are used. They're still generally very expensive, and so they're not kind of commonly available within the clinical realm. And then, as I mentioned, often the diagnosis is made late. And so oftentimes, the full scope of this is not really done in a stepwise way, because someone's being brought to clinic who hasn't seen a doctor in 2 years and it's very clear that they have very profound impairments. All right, so these are just copies of some of the common tests. Some of you may have seen them, some of you may have done them. The one on the left is called the Montreal Cognitive Assessment, or MoCA. The one in the middle was designed through a VA researcher, and is called the VA SLUMS test. Stands for, funny name, stands for St. Louis, not slums. And then the last one, which is generally not used except in clinical studies now because they copyrighted it, is the Folstein Mini Mental State Exam. So some people have heard of that. But you can see in this MoCA test that they actually tell you kind of what you're evaluating in each section. So on the top, visual spatial executive function, it's got a trails test, a cube copy. You can't really read it, but basically that square is for a clock draw. I love clock draws. They tell me a lot of information. Oh. Naming, memory, attention, language, abstraction, delayed recall, and orientation. And the SLUMS test doesn't categorize them for you, but they're very similar in the types of assessment they're doing. When I work with a learner and I'm trying to teach a learning healthcare provider how to execute these tests, I tell them that it's not just the number that you get at the end, it's not just counting up how many did they get right and how many did they get wrong. For me, it's like watching how does someone do it. If they draw an incorrect clock, how is that clock incorrect? If they do a perfect clock, did it take them a really long time? Did they have to erase and start over? And how are they processing it as they execute the test? All of these tests, for the most part, theoretically take anywhere from 5 to 15 minutes. So these are what are designed for primary care settings. So this is the list of the functional parameters that we look at to determine whether or not someone has functional impairment. So activities of daily living on the left, what I tell people are what just on the basic level a human being needs to survive. You have to be able to eat, to bathe, to walk, to empty your bowel and your bladder, to get dressed. Instrumental activities of daily living, which is on the right, is what we need to operate in modern society, right? You have to be able to use a telephone or some kind of communication. You have to know how to manage money, how to take care of your home, how to navigate transportation. And then these are the functional assessments that most people think of, but I think one that often primary care providers and even some neurologists miss is to also look at social and occupational function. So the example that I give is when I was still working at UC San Francisco, I had a gentleman who was a professor emeritus of biochemistry, brilliant man, very high functioning, had slight decrease in his number on a cognitive assessment. And it was really the corroborative information from his wife who was very worried about him, because he was reporting that he was doing his taxes, he was still editing his research papers with his graduate students, and really he could not edit his research papers. They were all over the floor, and his wife was going into the computer and trying to edit them. And she was the one who was organizing all the taxes. And so, he could still manage his money, he could still, make his breakfast, but from an occupational standpoint, he was not functioning in the way that he used to. So here's the diagram of the most common types of dementias. Alzheimer's is the big kind of maroon slice of the pie. Generally, we think of it as about 65, 2/3 of the total types of dementias. Vascular dementia is the blue wedge, and then there's kind of this area of mixed where it's probably a combination of Alzheimer's or vascular, and vascular is generally about 20% of the dementia population. Now, when I say mixed, the reality is that a true diagnosis of Alzheimer's can only be made by brain pathology. So when we say someone has Alzheimer's, it's our best guess that someone has Alzheimer's, unless we actually do a post-mortem biopsy of the brain to look at the tissue. We cannot know for sure if it is Alzheimer's dementia. So there's sort of this gray area where people who have vascular dementia might be labeled Alzheimer's and vice versa, because sometimes it's hard to tell. Dementia with Lewy bodies is this dark blue one. That's about 15%. Frontal temporal dementia is the yellow one. That's less than 5%. And then sort of everything else is kind of around 1 or 2% combined. These are some typical brain images from an MRI. So you can see here's the normal brain. So the brain tissue is the white gray area. That's the skull. This is if I were to cut your head straight down this way. And then this is mild cognitive impairment, a little bit of shrinkage. And then here you can see Alzheimer's compared to the normal brain. There was a lot more shrinkage. This area, which is what we call the ventricle, is a lot bigger. That space is bigger, and generally there's a lot more space in the brain compared to brain tissue. Similarly, A is a scan, this same view of Alzheimer's disease. You can see that here, which is kind of where the hippocampus is a little bit more shrunken. White generally denotes damage. That is where there is brain damage. And then B here, you can see that this is Lewy body dementia. It looks fairly similar to the Alzheimer's, except that you don't have focal damage in the hippocampal area. C is frontal temporal dementia. Now, this is a different slice of the brain. This is if I were to cut the brain parallel to the floor. And so the top is the front part, forehead. The bottom is the back of the head, and you can see how much more shrunken the frontal lobe is in that scan in the top right. And then this is vascular dementia. And so those white flares, again, white in an MRI is some kind of limited blood flow. So some kind of what we call ischemia. That's what it looks like when someone has a stroke. And so vascular dementia, this is just one example. People have strokes in all kinds of different places on their brain. So where that white flare is and how a person's symptoms manifest really depend on where their stroke is, or mini strokes for that matter. Oh, I should say also, when I say that imaging does not make or break the diagnosis, is that I could have someone that looks like they have a lot of atrophy on their brain scan and be functioning totally cognitively normally. And I could have someone who has a normal looking brain and has significant cognitive impairment. So that's why we say, brain imaging can help, but it does not really, you can't solely go by it for diagnosis. All right, I won't go into super detail. This is a overly involved table of the 4 common types of dementias: Alzheimer's on the top, vascular, Lewy body, and frontal temporal dementia. My main purpose with this is to show you that you can see with Alzheimer's, the main symptoms, early and mental status symptoms, are memory loss. That's how we know of Alzheimer's, as the memory impairment dementia. But if you look at vascular, Lewy body, and frontal temporal dementia, memory is not at all one of the early symptoms of those types of dementias. So for vascular, again, it really depends on where is the injury to the brain from your stroke or mini strokes. For Lewy body dementia, often the initial symptoms are very profound, very vivid visual hallucinations, what we call REM sleep disorder, Capgras syndrome, which is like misidentifying a person or things. And then frontal temporal dementia is personality changes, apathy, poor judgment, disinhibition, sometimes profound speech language issues with expressive aphasia. So, so this is really mostly just to show, again, memory is not the only criteria for dementia. All right, so to get to the meat of today, these are the cognitive domains. This is how, as humans and psychologists and psychiatrists and neurologists, basically it's our way of taking everything that the brain does cognitively and to try to categorize them in a way that can help us understand cognitive processing. So, learning and memory. I start with this one because this is the one, again, that everyone thinks of with dementia. This is my dad's mom, the one you've seen in the other pictures. And as I mentioned, my grandmother had sort of the very sweet, extremely forgetful type of dementia, the one where her like existence loop was 5-second loop. Like you said something to her, she forgot it, she asked it again, 5 seconds later she asked it, and that was the kind of relationship we would have with her. So when you have difficulty with learning and memory, and there's multiple aspects to making a memory. So you have to, I have to read something or see something or hear something, and I have to encode it in my brain. And then it has to be important enough to me for my brain to want to actually put it into memory. So, which is why I don't remember a thing about physics and biochemistry. I did a lot of memorization of them, but those things were not important for me to retain. We have to prioritize because there's too many things for our brains to hold on to, so we have to know what we want to remember. And so sometimes if someone hasn't encoded something from the beginning, maybe they didn't hear it, significant hearing loss, or it wasn't emotionally important to them, they're not going to remember it. If they weren't paying attention, they're not going to remember it. So it wasn't that they had a memory problem, they had an attention encoding problem. But that can sometimes get confused, and that's why people who have significant hearing impairment get confused for having significant memory problems. But if you have a learning and memory domain problem, you are having an inability to acquire, encode, and remember new information. So you have to be able to retrieve it also. You forget recent events. You forget what you just ate for breakfast. You misplace objects. These are some of the early signs, like I lost my glasses again, over and over again. This is like my grandmother, repetitive questions, repetitive statements, telling the same story 10 times. As a healthcare provider, I sometimes think about this when I have had a patient who, I don't have a clinic anymore, but who was always very reliable, came to clinic appointments on time, and then all of a sudden is missing, or, oh, I thought the appointment was next week, getting off track on their calendar. And that's a red flag for me to look into whether or not there's cognitive changes happening. Complex attention. So in order to navigate the world, again, there's so much information and stimulus all around us. Our brains have to be able to selectively focus on things and not get, wheeled away into every little thing that's communicating with our body. And it's a really remarkable thing that our brains can do, because as you can imagine, you walk down the street or you walk into your kid's classroom, or, it's like, blah, 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 like too many things coming, and you got to know, like, what do I pay attention to? And that's what the brain helps you do. But if you have an impairment in your attention domain, as you can imagine, now you have difficulty with multiple stimuli. You are easily distracted. You're kind of looking at one thing and then whoop, you jump to the next thing. You can't stick to any one thing. You are unable to perform, mental calculations or significant problem solving. So this, as you can imagine, makes it very difficult for someone to plan, to make a complex decision, to problem solve. And this last bullet is really integrated very much with the domain of executive function, because they work together. You have to have enough attention to be able to plan. You have to have enough attention to be able to problem solve. So those domains work together. I should say also that attention domain, so within Alzheimer's dementia, the primary domain to get impaired is generally memory and learning, but usually the second domain to have the most significant impact tends to be the attention domain. Executive function. This is all of our higher order brain processing, what separates us from chimpanzees and monkeys, so some would say. This is where we do verbal reasoning. This is how we problem solve, how we multitask. And I think what some people are surprised by is that it's the executive function domain that has to do with whether someone is flexible and adaptable or very rigid. They have to have everything exactly the same. And so if you have an impairment in executive function, you lose these abilities. You are now easily overwhelmed by even the simplest tasks, even things that you've always done before and maybe had muscle memory for, but you get confused about what to do. You are no longer able to reason. And so this is why a lot of times, sort of as counsel to caregivers, once someone is sort of past early stages of dementia, where you might still be able to reason and orient to them and correct their date and time and place, don't try to reason with someone, because when they have lost their reasoning abilities, you will get frustrated, they will get frustrated, and you will just be in tension all the time. So disinhibition. This is where executive function can manifest as very sort of behavioral symptoms. Disinhibition, impulsivity, lack of filter. So this is someone who might start saying all kinds of interesting things to a total stranger in the store. And this may seem like a domain later that we call social personality domain, but it's actually also coming from the executive function domain. So language, as one would imagine, if you lose language ability, now there's two parts to language, as we've talked about in the brain image. There's expressive language, to be able to speak, to be able to write something, to communicate by hand. And then there's receptive language, that I can read something, hear something, and I know what somebody means, and I can understand that. So either of those, and both of those, can become impaired. And this results in someone having what we call word finding trouble, beyond normal aging. This is where we call impoverished speech. So this is where someone's normal inherent learned vocabulary begins to diminish. So for instance, Ronald Reagan, who was one of the first major public figures to publicly say that he had a diagnosis of Alzheimer's disease, for those of you who remember him, he was also a professional actor. His speeches were incredibly eloquent, very full of rich words throughout his presidency. After he left his presidency, linguists looked at his speeches, because he continued to give speeches, he ran a foundation, et cetera. And you can see that his vocabulary, the breadth of his vocabulary in his speeches really begins to diminish. till he was diagnosed with dementia. So that is what we call impoverished speech. Word salad, where things, they might be some actual words, but they're connected to words that don't make a sentence, that you can't actually understand, or they might be complete just vowels and consonants, and you're not sure what the word is at all. And then, of course, comprehension difficulties. Because we're talking about language, I have to, as a healthcare provider, be sure that I've ruled out a hearing problem, because there are many people who, it may not be that it wasn't identified, it may be that they've resisted wearing hearing aids or resisted getting help for their hearing. That's very common also. I put this picture of my grandparents up because when my grandmother was young, this was during the Japanese occupation, and she taught in a little preschool, and she learned a lot of Japanese songs. And long after she lost her English and Chinese language skills, surprisingly, at least to me back then, because I didn't know that much about dementia when she was going through this, she could still sing Japanese children's songs completely from beginning to end, even though Japanese was not a primary language for her. And part of that is because music center in the brain is at a very different place from the language centers. And so sometimes people can sing an entire song or multiple songs and yet not be able to speak to you when you say, hello, how are you? I think that's fascinating about the brain. Okay, the perceptual visual domain is exactly what it sounds like. It is how we perceive. It's our sensory ability to navigate the 3D environment. So if we have trouble with processing, what we feel, what we see, what we hear, what we taste, those things make it hard for us to do certain things. So misperception is if I were to, this is like, what's that book that people say, the man who mistook his wife for a hat or something like that. And then misidentification, where, my grandfather looks at me and thinks that I'm, his wife or his daughter. Visual spatial difficulties, this is the 3D trouble. This is someone who cannot drive their car, navigate it safely, or maybe cannot drive their power scooter. And this picture basically reflects my grandfather when we had to take his driver's license away because he was getting dings and hitting into things on his way down the road, and really shouldn't be driving. So same with language, having to rule out hearing problems, we have to rule out a visual problems because there's so many visual things, whether it's cataracts, macular degeneration, all kinds of things that can affect vision. And so we have to be sure that we've addressed those. All right, so the last domain is social cognition. I think this is some of the hardest domain impairment for caregivers to to weather because it is profoundly emotional. This is when our loved ones have a change in their personality, their emotional expression. This is the example I gave earlier of the sweet grandmother who was always lovely, baked cakes for everyone, and now is, nonstop cussing and angry and aggressive. So we can see very marked changes to emotional expression, everything from blunt, being just flat-faced, no emotional expression, to, volatile, labile, like crying and laughing hysterically, and then, in a pool of tears. Changes to personality, apathy, loss of interest in anything, all of the things that they used to love. You try to engage them and they have no interest anymore. This could be someone who has basically a manifestation just like someone with obsessive compulsive disorder. The picture of the toilet paper is because I had a woman who just nonstop would tear squares of toilet paper and rip them up into tiny, tiny, tiny little bits, and just nonstop had to do that in order to keep herself, her coping strategy. This is someone who can become very aggressive, someone who may have delusions, hallucinations. And so, some of the delusions and hallucinations might stem from a perceptual visual domain impairment, but you can also see it in just a social cognitive domain impairment. And then I think some people are surprised that it's this domain that can cause impairment in hygiene, eating patterns, and changes in sleep. So with all of that kind of now in your back pocket, I'm going to walk through these statements. And again, these are only a small number of the many, 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 many things we all experience every day with our loved ones with dementia. But I want you to kind of just get a sense of kind of how I think about things. What I just advocate for you is that the last thing that you ever want is for a doctor to hear what you're saying and just say, okay, take this antipsychotic and that will solve your problems, okay? Because medications are a small sliver of what can help us with dementia, but so much more is about how we figure out what are causing the behaviors and the triggers that are happening for our patients. So I told him 5 times not to do that. This is, of course, inherent to a lot of memory-based dementias, but also in my mind, I'm thinking, how is this person hearing? Are they hearing the things in the first place? If they are hearing, or if they need support hearing, do they need a pocket talker? Do they need hearing aids adjusted? And is this, if this is a memory issue or executive function issue, then the counsel becomes helping the caregiver understand that trying to force the person with dementia to hear what you're saying and understand it is not going to work, unfortunately. And so this is where having to help all of you as caregivers recognize that the battle, we can create battles for ourselves if we keep persisting on, you just do it once, But once we can recognize that if someone has a profound impairment in executive functioning or memory, we're trying to climb up a hill. So there's some amount of accepting and adapting to what a patient can do in order to get ourselves away from that battle with, I told him 5 times. He keeps urinating everywhere except the toilet. So there could be a lot of things happening with this. So if this is a man, I would say, well, okay, have we ensured that this is not an enlarged prostate issue, that he doesn't have a constant urgency to pee because of prostate enlargement? Maybe we need to address that. Maybe there is overactive bladder, which is also common in women. And if the bladder is sort of hyperactive, maybe we need to kind of treat the hyperactive bladder. It could be a visual perceptual difficulty. He does not recognize what a toilet is anymore. He looks at it and he doesn't know what it's for. Or he's thinking that anything round, the trash basin, the planter, it's kind of round. Is that where I can pee? Maybe they just doesn't know. Or maybe it's someone who physically, because of arthritis or otherwise, physically can't get to the toilet fast enough because to walk to the toilet from the living room, to take down a button and zipper pants and a belt takes too long, and he just has to go now. And so in those situations, cueing them regularly to go to the toilet, making sure they have pull-up, elastic waist pants instead of dealing with a belt and a button and a zipper. Trying to think through all the reasons why someone might have difficulty making it to the toilet in time, and do they need cues or signs? Sometimes simply putting up a sign on the door or arrows to say, this is where the toilet is, and writing down the steps, lower your pants, pee, flush, wash your hands, may be what they need if they can still read. My wife won't sit still to eat. So this could be the attention domain disorder, or it could be executive function. It could also be visual perceptual disorder. There are lots of reasons why someone might not want to sit and eat. If we think about the attention disorder domain, this is where someone, again, is easily distractible. Too much stimulus is getting in their way. And so to sit down at a proper meal and eat for 30 minutes with their family becomes very difficult, and it becomes stressful for that person. And they might just need to, be clear and be accepting of, we are not having sit-down meals anymore. We are going to put out hand food, finger food throughout the house in little bowls that she can take, whenever she's hungry, whenever she feels the hunger, she can find something to eat. And as long as she's getting enough to eat through the day, we'll call it good. Maybe it is a problem with the plate has a serving of meat, it has vegetables on it, it has rice and mashed potatoes, and there's too much on the plate. It's too distracting. She doesn't know what to eat first. And in that case, you might say, just give a small plate with one food item and let her finish that. And then if she's still hungry, take it away, give her another plate with one food item, rather than expecting her to know what to do and what to start with first in a plate that has too much stuff on it. So these are sort of the things to think about in that example. And again, these are all just examples, I could go on and on. Dad insists someone is coming after his money. This could be a number of domain impairments. But if someone has lost their reasoning ability, if someone has, on the social domain, has some paranoia and has lost trust in things, then again, you're not going to be able to reason through this. And so rather than trying to reason and fight and like the money is fine, there's nobody at the bank, is to try to, go along with that person's, theater. So when we talk about, enter your loved one's reality, and this can be hard as a caregiver because you're like, it's totally off the wall. And you're like, yes, you go into their reality with them and you find a way to soothe them and to comfort them within that reality. You don't deny it because then they feel dumb. You don't say, no one's taken your money. Like, what? That's totally, you don't make a judgment about it. You just enter their reality and then you try to soothe them within it. Okay. She keeps falling, missing the chair. This could be a number of domains too. This could be visual perceptual. They're not recognizing that the chair is not right behind them and it's 6 inches, 12 inches behind them and they try to sit and they fall. It could be attention. They're not paying attention because they've gotten distracted by the dog that ran across the room. Lots of things for why a person is having trouble navigating. And so, these are individuals who may need, real close supervision. I tell people always, because there's so much fear of loved ones falling, and the reality is there is no way to get rid of fall risk when someone has, increased vulnerability falls. We can mitigate, we can reduce, but do not put the burden on yourself because it's impossible to be with someone 24/7 and keep them from falling. Because you might go to the bathroom because you need to go to the bathroom and take care of yourself as a caregiver, and your loved one may fall, and it's just that is what it is. This is what we're dealing with. And so I really want people to not feel like they weren't there, and that is why their loved one fell and broke their hip or broke their wrist or bruised themselves. So with falling, missing the chair, sometimes or getting up and not getting their walker, this is where I say get some very bright electric pink electrical tape. Wrap it around the walker so that the walker really stands out and you can see it and it's a visual reminder, get your walker. And same thing with, sitting in a chair. Sometimes I say, draw little feet or put little stickers of feet next to the chair so that someone has a target to go to when they're going to their chair. These are all strategies to really try to help bolster when someone has different impairments in their perceptive domain. Mom was always sweet and now she's cussing nonstop. This is a hard one because I would say this happens a lot with frontal temporal dementia, any kind of shift in inhibition, normal inhibitions, social graces. And sometimes there is no way to get around this. Sometimes this is where you make a little business card that says, I'm sorry, my loved one has, dementia. And if your loved one is out in the community with you and they start cussing at someone at the store, just out of the blue, you slip them the card so that they can understand and not get all upset at you and your loved one. But this is a difficult one because there isn't a good way. You can't really say, Mom, that's totally inappropriate. She's not going to understand that. You can't reason with that. So you just have to accept that. And then I try to tell him those people he sees aren't there. Again, going back to, the ways that I think about this is, that could be a visual issue, could be a visual perception issue. Sometimes, different things that a person sees because of cataracts or macular degeneration, like if they see a reflection in the mirror, they don't interpret it correctly. And that's partly because the vision input is wrong or it's fuzzy. And so, again, entering their reality, don't say there's nobody there because they see someone there and that is their reality, even if it's not your reality. And so find a way to soothe them and comfort them. Even talk to the person that they see and just say, oh, hey, Joe, seeing you again. Can you, we're busy right now. Come back tomorrow or, go away for a week or something. Just you can engage within their reality to make it less threatening. But don't try to correct or say that that person's not there, or you know, you're just seeing things, because it's real to them. So that's just a quick example of what I had in the beginning. And so I know you've probably heard this before, but as a caregiver, it is so hard to, there's so many changes with dementia that make caregiving and being with your loved one really, really challenging. And it is a long road. So I'm going to just repeat what probably you've heard before, where it's not you, it's not your loved one, it's the dementia. It is the dementia, and our goal is really just to try to understand and adapt and go with the flow as best we can, and get support for yourself, whether it's a Grace support group, Lumina support group, friends, church, you know, church colleagues, but it's very difficult to walk this road alone. Medication is only a small part of what's needed, and medication will only get you so far in success in taking care of your loved one. There is a role for medication. I think often it's overused in the general primary care setting, but you need to know kind of all the other things about how to creatively do detective work to figure out, why is my person behaving like this? In the same way that if you were raising children, and this is before your children have language, you know, you are trying to figure out, why is the baby crying? Why is the baby grunting? You know, this is the same thing. It's not to say that our loved ones have become babies, but if they have lost their language abilities, it is our role to kind of do the detective work and figure out what is causing the person's behavior. Sometimes behavior is a primary manifestation of dementia. Sometimes and often behavior is some way that that person is trying to communicate, because they don't have the words for it. So if we can just remember that, then we can do a better job of trying to figure out, you know, what that person needs. And then we can, you know, adapt schedules, adapt the environment, adapt expectations, adapt our care approach so that we can be more successful. And with that, this is just some of the upcoming things. So April 10th next month, this will be at C3. We are doing a screening and Q&A of an award-winning documentary called Wine, Woman, and Dementia, about caregivers of dementia. It's not just for women, it's, you know, applies to all. It's just that the documentary focused on women caregivers. The next session for this 4-part series will be in June, and that will also be at C3. And then we'll do one in the fall and one in the winter. And I just want to say that, you know, these sessions are supported by, you know, community grants and our gratitude to private donors. And so we do have a couple of sort of fundraisers coming up. The Grace Center, again, which is offering respite for caregivers, on Wednesday next week, the 19th, they are doing a Burgers and Brew event. I think there's information on the back, right? So for those of you who want to help support the Grace Center, which is a wonderful partner of ours. And then Lumina on Tuesday, the Hazelwood Ensemble, which is a cappella choral group, which I sing in here, is doing a benefit concert at Grace Lutheran on Tuesday night at 7. All proceeds, not proceeds, but everything collected will go to Lumina. So it's free, but they are accepting donations. And with that, I will open it up to questions, and I'm open to staying later than 1. So if anyone does want to ask questions, I just ask that please don't ask a personal question about yourself or a loved one, because I can't technically give medical advice here. Thanks. Yeah.
Parkinson's, I think Parkinson's was one of the slices.
Mm-hmm.
Does Parkinson's always lead to a dementia?
Yes, if someone survives with Parkinson's long enough, generally Parkinson's will lead to Parkinson's type dementia. Yes. Mm-hmm.
Is it obvious to the person that they have dementia?
So yes, in the early stages, most people do recognize that they are struggling with their cognitive function. You know, when I said that we have to rule out other things, it's not uncommon that in early stages, you know, when someone still has awareness, that depression is kind of concomitant with dementia, because people recognize that they're losing their abilities to do things that were always very easy for them or natural for them. Mm-hmm.
How important is it really to diagnose what kind of dementia is it?
That's a great question. You know, there are very few treatments, the dementia treatments, I would say, they're kind of ho-hum on how beneficial they are. There are some differences in terms of some medications like Lewy body dementia, which tends to be more easy to identify, but you don't want to use certain medications in Lewy body dementia because someone can have a atypical response to them. Some of the approved medications for things like Alzheimer's are not FDA approved for other types of dementia and are not effective. The most new medications, which you've probably heard about, all the controversy about the new medications, those are only for Alzheimer's dementia. So from the big picture, I think as a caregiver, our approach is the same to anyone with a type of dementia. It's just trying to understand what are the main manifestations that they have and what are the main impairments so that we know how to support them. Whether to use and which type of medications to use, I think that's where you have your healthcare provider's input as to what is worthwhile or not. Also depends on how many medications a person is taking overall, and how much, because I would say all of the dementia medicines, occasionally you have a person who has a profound response to them. I rarely see that. Most of the dementia medications, you start it and you're like, I don't know if this is doing a thing. And sort of you have to decide, do I commit this person to taking this, 1 or 3 medications for the rest of their life or a long time? Or do we sort of decide, what's in the best interest of that person based on all the other medications they have to take and their health condition? And actually next Friday is a caregiver luncheon at C3, which is free, a wonderful lunch for caregivers. And I will be talking about polypharmacy and medication management at that talk. So, yes.
To follow up on your answer to that question, I tell members of my support group, which is a memory loss support group for caregivers, the most important reason for getting a diagnosis is to rule out anything that might be treatable.
Mm-hmm.
And that is very, very important. You didn't mention that.
Yes. Yeah. So I think there's 2 reasons to get a diagnosis. The first is to be sure not we're missing something. So again, I had a patient in San Francisco. The family was like, she must have dementia. She's like not making any sense. She's confused. She's falling. She's can't drive. She can't cook. And I do a lot of my care as home-based care. I go into the home and I find hidden bottles of alcohol, in the cabinets under the stairs. And she had become a late life alcoholic because she had become so stressed taking care of her husband who had Parkinson's. And so once we took care of that, she did not have dementia. She was cognitively fine. Being sure we rule out hearing issues, et cetera. The other, I think, very important reason why it's helpful to identify dementia early is that because dementia progresses, you want to get your loved one's input on what they want for their life and their care and their living situation and what you can financially manage. You want to take care of that early before it's in the moderate stages where it's now too late to get their input on what they want. So the earlier you can identify, the more that you can plan ahead, because again, everyone with dementia at some point is going to get to a place, knock on wood, unless something else strikes them first, where they will need 24/7 care. And is that you? Is that a facility? Is that you with paid care help? That's what getting a diagnosis early allows you to plan and do. Mm-hmm.
How much does known heredity of, say, Alzheimer's influence in a diagnosis? And the related question, is there any statistics, information about how much, if a previous relative is diagnosed with something, that you have an X% chance?
Yeah, so for Alzheimer's, there's a small percentage of people who have familial Alzheimer's. I would say most people who develop Alzheimer's in the more typical sort of 70s, 80s, 90s is not familial. So there is not necessarily increased risk of family Alzheimer's diagnosis. It tends to be more when someone has young onset Alzheimer's, and these are people who are diagnosed in their 30s and 40s, 50s, who have Alzheimer's dementia, and those families are where I would say getting genetic testing, genetic counseling, if they want it, can be helpful. Mm-hmm.
What are your thoughts on pseudo dementia?
What do you mean by that?
Well, like it's not being diagnosed as dementia,
Mm-hmm.
fake dementia?
That the healthcare provider has labeled or that the
The healthcare provider.
Um, there's a lot of pseudo types of illnesses, and some of it can be manifestations of a psychiatric disorder. So I'm not sure if that's where, you know, where people manifest symptoms of some kind of real illness, but don't actually have that illness. And it's coming from some other type of psychiatric disorder. So I don't see pseudo dementia very much, so I haven't really come across it. Most of what I see is true diagnosis of dementia. So yeah, I don't know.
It's interesting.
Yeah. Mhm.
In the doctor's office, if you ask for, you know, the testing for dementia, do you prefer the MoCA over the slums? And can those actually determine if it's dementia, or do you need other things to go with it?
Yes. So I think I said Folstein Mini Mental State is now copyrighted. MoCA is now, for some time now, is requiring healthcare providers that use it to pay a fee and take a training and do it. So a lot of people are gravitating towards the slums simply because it's the only one of the ones left that is still free. But every healthcare practice kind of has their own. It's kind of embedded in their electronic medical record. So they're all very equivalent. You know, the mini mental state, the slums, and the MoCA all have roughly kind of an what we call sensitivity and specificity of like in the 80s and 90%, which is quite good. Meaning that if you have a score on one of those tests that is below a certain cutoff, and you have a functional impairment, and your healthcare provider has ruled out that there isn't some other clear reason why there's a cognitive impairment, then it is a high likelihood that that person has, you know, some type of neurodegenerative disorder. So yes, those tests are generally considered fairly good. Now, if someone, as I said, a very high intellectual baseline, or someone who is illiterate to begin with, or has, you know, baseline intellectual developmental disability, then that's where you might want neuropsychologic testing to really help you clarify, does this person have dementia, or is there, you know, something else going on? The other reasons for neuropsychologic testing, which can be helpful, is in some cases, getting neuropsychologic testing, it gives you much more information about where a person's strengths and weaknesses are, again, thinking about the domains. So it can be helpful in some situations in helping as a caregiver and your loved one to know what can they still do independently, what do they need support in, what kind of support, and how to think about their function based on strengths and weaknesses. You know, the 5-minute test in the primary care office is not going to give you as much information about that.
Yet she has macular degeneration, so how did they even say, you know, if she can even see?
Yeah, so they have different normative values for things like hearing impairment, vision impairment. There's modifications.
Okay.
Yeah. Some of those are not as well validated as the original tests where they were designed, but each of the tests that I gave examples of have sort of sub-test options for hearing impairment or vision impairment. And some also come in multiple language, like MoCA, that can come in like 30 some different languages.
Would we be able to watch the recording that you have?
That's our plan, is to post it somehow on our website. We'll figure that out
Who's
once
with-
we have it in hand.
On Luminous?
Uh-huh.
Okay.
Yes.
Or who decides on a driver's license, or when does that come in a diagnosis?
Okay, that's a great question. So someone yesterday had a question about when do you determine someone has incapacity? So in Oregon, driver's license is a functional determination. So an actual diagnosis cannot take away someone's driver's license. The DMV in Oregon is very careful that they don't go by diagnosis, even if someone has seizures, or, you know, they need to know what are the functional deficits a person has for them to determine whether or not they retest someone, bring them in, or just take the license away. So whoever is making the diagnosis, or even as a family member, you know, you're noticing, you know, my parent doesn't drive straight, makes sharp turns without checking, you know, whatever it is you're seeing, any of that can be reported to the DMV. You can no longer report anonymously, but any of that can be reported. And they look at those functional observations to help them weigh in on, is this someone whose license needs to be taken right away? Or does this person need to be retested, or can they go through driver's rehabilitation? So that's how the DMV determines whether or not driving is removed. So I always tell people, families come to me, it's like, dad cannot drive. You have to tell him, you have to take his license away. And I say, well, I can't do that. And it's made, honestly, it makes it easier for me. I say, Mr. X, I'm not here to take your license away. I'm required to report this to the DMV. It's up to the DMV to decide, you have an opportunity to go and test again or to do driver's rehabilitation if you want to. I simply have to report to them what I'm seeing. And so I have made reports. So when I first moved to Oregon, I made reports to the DMV, with a diagnosis of dementia. And they would always send it back to me and say, that is not sufficient. You have to detail the deficits that they have that make them unable to drive. So that's the driving issue. And then the capacity issue, so whether you're talking about financial management, legal decisions, contracts, et cetera, that from a legal standpoint depends on the question. So, someone, the example I gave is someone may have Lewy body dementia and have profound visual hallucination, cats on the floor, cows in the trees, whatever, and yet may be perfectly able to manage their finances. So just because someone has a certain aspect of dementia doesn't mean they can't still do certain functions. And so from a legal standpoint, if you're trying to figure out, do we take over the trust or whatever, the question always comes down to, does the person have the capacity for the specific question that you are dealing with? If not, then that function gets punted to their power of attorney or, whoever they've appointed, which is again why early identification is helpful, because oftentimes we see people who have not done an advance directive, have not set up a power of attorney, a trust, a will, and it becomes too late when you're in moderate advanced stage of dementia. Thanks for staying. Thanks so much for coming. And hope to see you in June.
Or next week.
Or next week.
Is that